My name is Olivia Balzer, and I'm currently in the Anesthesia and Surgical Assisting class, online class. It's VTHT1341, and my student number is E2794483, and I'm going to start by discussing the admissions forms for a surgery today, a spay. Then we're going to admit a 4-month-old female canine, a Doberman, who is 20 pounds. Her name is Noodle, and she is a young and healthy, and she did have some pre-anesthetic blood work performed, so I'm going to start going over those admission forms. So our practice software is AVAmark, and all of our medical records, including lab work, all of our TPRs, everything is permanent in AVAmark. We try to make it as paperless as possible. And we even scan in all of our documents and save it to the software itself. We also make sure that our software is cloud-based, backed up to each night, so we don't lose anything. But basically, we have our client information here, patient information, and then medical history here. We also are able to easily select laboratories that we've done and very easily be able to view what previous lab work looks like. All previous medical record history is also scanned in, saved, and attached to AVAmark as well. They would save under a special attachment that we would name previous records. We also do what's called history mode, and any previous records from a vet provided, we are able to, under history mode, enter in any vaccinations and previous blood work so that we can utilize our reminder system and make sure that each pet is up to date and they get reminded. Even if another clinic gave the vaccine, at least we can remind them when they need it again. So admission forms are very important when we first bring in our client and our patient. We want to go very carefully over our authorization for anesthesia and surgery. We want to make sure we get a current telephone number and make sure we ask them, are you going to be available at this number, because you never know what we might find and they might need additional services while under anesthesia or here. We also mark whether they accept text or not. A lot of clients do prefer text. We make sure they're feeling okay, that they haven't vomited or had any diarrhea or any trouble at home, or if they stopped eating. We make sure that they also did not eat this morning. A full stomach with an anesthetic patient can be very dangerous. A lot of times under anesthesia they can vomit, especially with the hydromorphone that we use for our pre-anesthetic. And that is a risk for aspiration under anesthesia or during recovery, and so we want to minimize that risk as much as possible by not feeding him the morning of surgery. We also note that who checked the patient in, so if we have any questions we can refer to that particular technician that checked in, and then we also mark who is assigned to as well, so that everything is clear. We ask them what medications are they currently on, when they last had them, and of course if they need any refills of anything while they're here. We also carefully ask them, do you have any lumps or bumps that need to be removed while they're here? And we have them show each lump they expect to be removed, and we mark it as well with either clippers or even a marker. We ask them if they want their nails done while they're here and their anal glands expressed. We ask them if they need a microchip while they're here, and we can do that. And then if they're here for dental procedures, we have an area where we can mark whether they're okay with dental radiographs and dental extractions and dental procedures, other than just the basic cleaning, or if they need to be called with an estimate after being assessed really well under anesthesia. That under anesthesia, of course, is the best way to assess whether whether there are any abnormalities going on. We also have, in the event of an emergent life-threatening situation, that they'll initial whether they approve life-saving treatments on their pet, including administrative medications, chest compressions, oxygen therapy, ventilation, defibrillation, or any other medical emergencies deemed medically appropriate. They will initial whether they authorize that, Or they can also initial that they do not authorize that. In this case, they will authorize the attending veterinarian to minimize pain and suffering in order to make attempts to contact and guide the client in the management of their care. And if euthanasia is medically appropriate, that they do need to assume financial responsibility of those fees. We discussed the risk of anesthesia. There's always a risk when they go under anesthesia. Pre-anesthetic blood work, pre-anesthetic radiographs are very important, especially for geriatric patients and high-risk patients before they go under anesthesia. But even with normal results from diagnostics, there's still always a risk from going under anesthesia. So it's important for clients to know that, understand that, and that they understand that, and they're okay with their pets going under anesthesia. Okay. We also have a pre-anesthetic blood work waiver if they absolutely do not want to do blood work. Some people don't. If if they don't want to do pre-anesthetic blood work, we just have a waiver, and it also lists out, why we recommend pre-anesthetic blood work, what the risks are, and what it can tell us about that pet's organ function.
Okay, so this is Noodle, and she's got her cage card with all the information on it, and then she's got a sticker that says surgery.
This is Noodle. She had a young pre-anesthetic profile completed. You can see here that her glucose is elevated just a little bit, most likely from stress, the doctor says. Her kidneys look okay, but her ALT and ALK Phos are a little bit kind of strange. Our ALT is just slightly low, total protein slightly low, and ALK Phos is slightly high. The doctor said that because she's so young, it's actually common for an ALK phosphatase to be a little bit high, and she was not worried about the ALT and total protein. She just recommends to recheck these values again in about a month. So she's still safe. Her CBC looks perfectly normal, and we also checked heartworm and tick-borne disease panel. Those were all negative. And we also checked for intestinal parasites, and that was negative as well. So she is deemed safe for anesthesia and for her spay that we're going to do later today. Along with the anesthesia forms, the admission forms, we fill out our anesthesia calculations. We want to find an appropriate pre-anesthetic that the doctor deems, medically necessary and medically appropriate for our patients. For Noodle, since she is 4 months old and she's getting spayed today, her blood work looked okay. The doctor decided to use dexdomitor as a pre-anesthetic. And we use the chart that the company provides. She is 20 pounds today, so we designated her as 0.29 mils to be given IM, and then we mark the time given, the route given, where we gave, and then who gave the injection as well. About 15 minutes after administration of the pre-anesthetic, our doctor decided to use our induction medication of propofol, which we gave slowly titrated to effect. It ended up being about 3 cc's, and we gave that through the catheter. And then at that point, she's able to be to administer the endotracheal tube and continue with prepping and getting her ready for surgery. We also, under anesthesia, gave her pain medication of Rimadyl. We gave her half a cc sub-Q right before going into surgery. And she woke up really well. Anesthesia was uneventful. We of course, took her vitals by hand every 5 minutes and wrote it down on our anesthesia chart. What we include on here is the time the anesthesia starts, so the time the propofol induction is given. And then we also write down what time the surgery starts. So we monitor her temperature every 5 minutes under anesthesia with an esophageal probe or a regular rectal thermometer. And then, of course, we monitor her pulse every 5 minutes, respirations under anesthesia, her capillary refill time, her mucous membranes, their moistness, and their color. We also monitor blood pressure, SpO2. We write down the percent ISO that we're at and the liter of oxygen that we're at every 5 minutes and the fluid rate that she would be on. We write also the time of the end of the surgery and then also the time of the end of anesthesia. And at that point, after the endotracheal tube is removed and everything shut off, we start writing down those values in the recovery section. And for recovery, we monitor her temperature, her pulse, her respiration, her capillary refill time, her mucous membranes, her blood pressure, and also her pain level until we monitor that every 5 minutes until she's extubated. Then we monitor every 15 minutes until all of her values are back to her pre-anesthetic values that she was basically upon entering the clinic. Discharge instructions after surgery. We have a whole home care instruction paper to go home with the clients, including the name, the date, the age, the signalment of the animal, the breed, of course, the client's name. It also includes the procedure that was performed. We want to include feeding instructions, of course. For a spay, we recommend a small amount tonight before bed, about half the normal rations, because sometimes after anesthesia they can be a little bit nauseous, and we would hate for them to throw up when they're at home and not feel well. We also usually have them give a pain medication and anti-inflammatory before bed as well, just so they never do experience pain throughout the entire recovery period. A lot of times that is a carprofen or some other kind of anti-inflammatory, and if they're not medically really suited to handle a NSAID, we will provide most likely an opioid or maybe tramadol or gabapentin tablet to go home for pain control. And then depending on what kind of surgery it was, we may or may not also send home an antibiotic. For a routine spay and neuter, we would not send an antibiotic home typically. If it was for like a fracture repair or a sick animal issue, maybe an internal tumor or injury, of course we would most likely send home an antibiotic in that case. The doctor would prescribe it. And then after hospitalization, care and exercise is important. We don't want to allow our pet to run or jump or roughhouse or use the stairs. And the reason for that is because they can develop a seroma, or they can even cause the incision to dehisce, and we don't want the incision to open up and start draining or invite an infection to inhabit the incision area. And of course, we don't want any swelling and a seroma to develop around the incision. That's also pretty scary for the owners to witness. We want to keep them basically in a kennel or enclosed area for probably 3 to 5 days, leash walk only outside to use the bathroom. And we want to continue to limit their exercise and leash walk only for 10 days, or at least until the sutures come out. We talk about they need to come back in 10 days for suture removal, or if they didn't have sutures and they just had skin glue, we'd like them to come back again still so we can recheck the incision, make sure it's healing well. We let the owners know to monitor the incision for any redness, swelling, discharge, any excessive bleeding, or any problems. A little bit of discharge, clear or bloody, is common that first day, and they can clean around the incision with a little peroxide if needed. We want that incision to stay clean, of course, at all times throughout the whole recovery period of the 10 days. No bathing or roughhousing again, or vigorous exercising. No water should be introduced to that area for 10 days or until those sutures come out. Sutures are staples. We also want to keep an e-collar on at all times if it's an abdominal surgery or really any surgery where they would have access to and they are able to lick or scratch at. We don't want them to scratch open the incision. We don't want them to irritate the incision and introduce infection to the area. So the e-collar is best around their head, those cones, to keep the incision safe. A lot of times if it's been a surgery around their face, an eyelid tumor, or surgery on the eye, or nucleation. We also use a cone to keep them from being able to scratch at their face. So we also note to make sure at our next visit should be within 10 days in order to remove the sutures or staples or just recheck the incision. We also have handouts on post-care pain management. There's some information regarding how to tell if your pet is in pain, why it's important to manage the pet's pain, and how to know when your pet is hurting, such as a cat with hiding, or a dog, not wanting to eat, just not acting itself. They could possibly be in pain, and to definitely make sure they let us know so we can dispense something for pain or possibly recheck the incision. We also give them, if they go home with pain control, and it happens to be an NSAID, we also have an anti-inflammatory handout which talks about the benefits of an NSAID, the risks of it, the side effects, and what you can do.
Okay, when restraining a small dog for a jugular blood draw stick, you want her sitting up is best, and then gently lift her head and push it to the side, and you expose the left jugular vein, and then gently turn her to the other side and you expose the right jugular vein. For a cephalic, you just pull her close to your body, pull her head towards your body, push out that right front leg, use your thumb to hold off the vein, and then you expose that front cephalic vein. For a lateral saphenous vein, you turn her to the side. You want to hold up her abdomen there, and then you would hold off just behind the stifle, and then you expose that saphenous vein, the lateral saphenous vein, for your blood draw to extract blood from that vein.
Okay, I want to demonstrate how to safely get a dog out of a kennel. So first of all, you want to have your leash ready, and you want to make sure that your patient is friendly and not aggressive. And you open the door just enough to where you can slip the leash on. Good girl. And then you can let her come on out. Good girl. Okay, I'm going to demonstrate how to safely get a small dog in and out of a kennel. A small cage. Okay. So you have your little dog, and you wrap your arms behind the hind legs and in front of the chest. So you can hold her like this, and then you carefully place her into the cage. Feet first. And then once she's safely in the cage, you can take your leash off and then close the door behind you. And then how to get her back out again is you gently open the cage door just enough where you can slip the leash on over her head so she doesn't leap out. Alright. Okay, and then you want to support her front end and wrap your arm around her back end and pull her out. And then bring her to the ground. Girl. Okay, so we're going to demonstrate how to properly apply a muzzle. So I usually stand behind her with a leash, and I'll put this muzzle with the nose and the all of the stuff on the bottom, and slide it right over her nose, and then you wrap or you buckle it behind her ears. And then this nose piece comes up around and attaches to the back of the muzzle. It's okay, right there. And that's how you put on a muzzle. Good girl. Okay, I'm going to demonstrate how to put on an e-collar. So this is a nice snap one. And then you turn it around so it's right, so this is right side up. And then you snap it pretty snug right behind her ears, and you make sure you do as many snaps as possible so that she can't get out of it. Good.
Okay, this is Sammy. We're going to do an exam on her today. First of all, I'm going to get her weight. She's a small dog, so we're going to use our baby scale. Okay. Good girl. Alrighty. So she's 9 pounds even today. Next, I'm going to take a rectal temperature. Okay, so I'm going to take a rectal temperature. I've got just a regular thermometer here. It's got a cover slip on it and it's some lubricant. And I'm going to take her temperature. Good girl. We'll do a rectal. Good girl. So her temperature is 100.4, which is normal for dogs. Next, I'm going to get her heart rate. Use my stethoscope. And I'll time a beat every 15 seconds. And then times that by 4. Okay, so I got, hang on baby, I got 30 beats. So times that by 4 and I get 120. Easiest to hear it on the left side. And then it's a good idea to listen to her lungs and her gut sounds as well. And I'll get a respiratory that way as well. I'm listening for any cracks, crackles, or wheezes in her lung field, and any abnormal gut sounds. She sounds clear. So she's about 20 breaths per minute. And I look at her gum color, it's nice and pink. Check her capillary refill time, which is less than 1 second. And then I palpate under her chin for any lymph nodes that are enlarged. Palpate prescapular lymph nodes, inguinal lymph nodes. I don't palpate anything enlarged. Popliteal lymph nodes, they all feel normal. And then I'll check her ears. Using an ophthalmoscope, check for any inflammation, heavy debris, or ear mites. It's okay, good girl. That one looks good. Looks good. Good girl. Then I want to check her eyes and her face, make sure there's nothing abnormal. So it looks good there. And the next thing I do is I'll palpate her abdomen. Make sure I don't feel any masses, anything hard. Kidneys feel good. There's no pain elicited on the palpation. And then I check her rectal area to make sure everything looks good there. And we'll check underneath her belly to check her skin, make sure there's no redness or pustules or anything abnormal there. What a good girl. She looks really good. Everything checks out really good.
Okay, now I'm going to perform a TPR and an exam on Bowie here. He's so sweet. So first I want to get his weight on the scale. Good job, bud. You're sweet. Okay, so he's 13.4. And I'm going to look at his mouth. He's so good. Make sure his mouth looks okay. Oh, no, it's okay. Let me see. Good boy. He's got nice, a good capillary refill time. It's under a second. And he's got a nice pink mucous membrane, so that's good. And I'm going to get his heart rate next. Okay. Good boy. Yes, you're good. It's always tricky when they're purring. He's such a sweet cat. Next I'm gonna do his rectal temperature. He's not gonna like this so much, especially since he's got a catheter back here. Good boy. Oh, good boy. You're so good. Okay. You can see the temperature is 100.5. You did so good, which is normal for kitties. And I want to make sure I write it all down. And his heart rate was 140, which is pretty good. And then I've got it all on his ICU form right here. And then I want to measure out how much urine he had. So he's got about 70 cc's of urine now overnight, which is I think what the doctor expected. And then I want to kind of look in his ears real quick and make sure that looks okay. Of course his urine is very bloody, and he did get an antibiotic yesterday for it. Ears look pretty good. They're just a little bit dirty, just have a little bit of debris. Good job, bud. He is I would think he's an ASA class of at least 3, if not 4, since he was blocked, and we do need to do a cystotomy to get out some stones, because being blocked is a severe life-threatening issue. He's not blocked anymore, so he's probably down to a 3 ASA class, and his blood work all looked good, but he is kind of a high-risk patient. He's only 3 years old, so it's not too bad, but we do have some underlying problems, so we'll have to be very careful and watch him under anesthesia. I didn't hear any crackling or wheezing on his lungs, and there was no murmur heard on auscultation of the heart as well. Here, honey. So checking his skin turgor, I just tint up the back of the skin, and it actually flops right back down. And then I'll palpate his belly. Oh, does that hurt? Yeah, I'm sorry. Actually, you're being pretty good, huh? It's not too bad. Yesterday he was really painful, but today it's much better.
Alcohol there. No, baby. I know. It's okay. Shh. You're all right. Shh. Hold still. Good girl. Stop. It's okay, Noodle. You're all right, baby. Good girl. It's okay. I know. See, that's ouchies, huh? Good girl. It's okay. It's okay. We're done. Alcohol on the area. Okay, put my hand right there. Sorry. Okay, now you can put your. It's okay, honey. Hold still. You're just fine. Okay, right there in the jugular vein. Good girl. Such a good girl. You can see the blood. Good. It's okay. Good girl. It's showing up so nicely. You're okay. You're okay. Good girl. Got it. She can't scratch me. And I'm going to draw from her jugular vein today. So I hold off at her thoracic inlet, and then I just spray a little bit of alcohol just to let that hair get out of the way. Part it so where I can see the vein. And I insert the needle bevel up right into her jugular vein and get about 3 cc's of blood. And this will be sent into our reference laboratory. I know. Let's see, let her head go. Okay, well, it's coming slow, but it is coming. Any chance her head can relax just a little more? That's better. Okay, I'm going to draw from the inner or medial saphenous vein on this kitty cat, get a little bit of blood. I can feel it right there, and I want my bevel up. Okay. And I'm holding off here. Okay. Right there, and I got a good flash. Right there. Good kitty.
So a minimum database for blood work for young pre-anesthetic patients would be at least a total protein and a PCV, a BUN, and an ALT in-house. That is just to check the minimum kidney value and the minimum liver value, and also make sure they're not anemic and they can handle anesthesia. So if a patient arrives who is actually sick with a high temperature, really high heart rate, or just abnormal finding on physical exam, and they're here for, routine surgery, what we would need is to perform blood work. If they're having trouble breathing, they're coughing, we would do chest x-rays. We would need to do these things before putting them under anesthesia, so at least they know it's safe to go under anesthesia and then their body can handle it. Some patients that are very sick, we would not perform a general procedure such as a dental cleaning or a spay or a tumor removal, because that would just increase the risk, and it would be unnecessary to have to increase the risk of a sick patient to go under anesthesia than to just wait until they're better. So on our young patient, dexdomitor, buprenorphine, propofol, and Rimadyl for pain, of course, those are all very common, very normal anesthetic protocol to use. It's very easy, and they recover really well on this combination of medication, and the pre-anesthetic of dexdomitor so helpful to help calm our excited young patients down in order to place a catheter. A geriatric patient, however, or a patient that has a heart murmur or heart condition or kidney condition, the doctor would not select dexdomitor and buprenorphine. Instead, she would choose probably a torbigesic and ACE or a hydromorphone. It's easier for the heart, especially if we have a heart disease. We don't want to give them dexdomitor as a pre-anesthetic. We would continue to use propofol in order to induce them, but probably at a lower dose, and probably a longer duration as well. The torbigesic and the ACE doesn't provide as much pre-anesthetic sedation or tranquilization as the dexdomitor does, but it is a little bit safer for their heart.
This is our control drug log. It's got our client last name, patient name, the drug, the number of the bottle, the date it was opened, the amount dispensed, the inventory balance, dispenser's initial, supervisor, and then 3 checks to make sure it's in the chart. And so I'm going to write down my patient that I gave the Simidol on. And today is November 4th, 19. And this was for Bowie. Pet's name was Bowie. And the last name was Bokaloo. And I gave him 0.34. And the inventory balance is 9.16. And my initials, and then Dr. Sears' initials, and then my initials to make sure that it's in the computer. And then I'll have Dr. Sears sign the supervisor initial. And that is how you do a control drug log entry. Okay, so an overview of the parts of the anesthesia machine. We have our Y tubes, the rebreathing tubes, and they connect to the patient. And they connect to the anesthesia machine. And so the oxygen, of course, starts at the oxygen flow meter, and you're able to adjust it by this knob here, and it flows to the vaporizer, and it either bypass it if it's off, or if it's on, it will collect gases that are vaporized and carry them through the machine in through the inspiration valve that again goes to the patient. Patient breathes out, and usually they'll fill up this reservoir bag with gas anesthetic. We've got our inspiratory valve, then this is the expiratory valve. This here is the pop-off valve, and you can close it if you want to test your bag or fill up the reservoir bag or even test the machine, but you've got to make sure you open it again. Otherwise, the pet will not be able to breathe out, and you can really damage their lungs. Respiratory valve, and some of the waste anesthetic gases will go up past the pop-off valve and into the scavenger system, or some of it will pass through the soda line, collect excess carbon dioxide, and then be rebreathed back into the patient. And you can control how much that happens, of course, with your pop-off valve. All right, so I'm going to demonstrate the non-rebreathing system. So here are the proper tubes. This side goes directly to the patient. This type of thing is used for those patients under 10 pounds because they're so small. There's a lot of dead space that ends up in the reservoir bag, and it's just not healthy for them to really rebreathe that anesthetic gas. So what we do is we will connect our so from our oxygen source, it goes to the vaporizer, and it can either bypass or it gets filled with the vapor. The oxygen comes out here, travels through this tube into the vaporizer, and then comes out this side with the tube coming around, connecting to the rebreather system through this clear tube. And then the gas directly is breathed into our patient here, and then they exhale into this reservoir bag, and then the exhale travels through the blue tube directly to our scavenger, which is then pumped out into the scavenger system. So again, this is a very kind of a wasteful system, but it's a lot safer for our really small patients. So we've got our box here, our chamber, with our kitty inside. And it's hooked up, it's got these two ports where the oxygen can come in, and it's connected to the rebreather. Here's our anesthesia machine and our reservoir bag here. And it's connected to the isoflurane, which pumps in through there where the kitty will breathe. And then our oxygen is up. So I've got it set on 5 here so that I can go ahead and induce anesthesia for this kitty who's blocked. This is our oxygen source, and it says it's in use, and then our plug, and then there's our gauge, and then the lines, and then this is our scavenger. It's vacuum scavenger, so it's an active scavenger.
So I have a rebreathing circuit here, and I'm going to perform a leak check. So I'm going to plug off the end, close my pop-off valve all the way, and I'll use the flush to fill up my bag. Make sure it's plugged. And the pressure's staying right there at 40, and I don't have any leaks, so we're good. I'm going to make sure I open my pop-off valve again so that's not stuck down. So for her monitoring, I want to place an esophageal stethoscope, and I make sure it goes, of course, into her esophagus, not into the tube. I also have an SpO2 probe applied to her ear to measure blood oxygen level. So this is my esophageal and ECG stethoscope. The temperature on it, the monitoring, and also the SpO2. Our endotracheal tubes are measured the size, the width of this tip is the width between the dog's nasal cavities right there. And then the way to check if it's leaking or not, or if it has any leaks in it, you know. All right, and then you kind of squeeze right here and see if there's any leaks right there.
Her blood pressure, and I'm going to use her right leg, right front leg, with a size 3 cuff. And so I'm just listening for that systolic pressure. Yeah, okay. So then I use the pressure until I can no longer hear the pulse, and then I let it off just enough to where I can hear it again. And I do this 5 times just to get an accurate reading.
I'll continue to monitor her temperature with the rectal thermometer. And then if she starts to get cold, I will put on a heat blanket for her.
This is my Dr. Sears. She's my preceptor who's been helping me. We wave to my camera.
Come on.
Wave.
Stuff like this. All right, so we're getting ready to place an IV catheter here in the lateral saphenous vein. So I'm going to shave an area first. Make sure I have good exposure of my vein. And I'm going to use some chlorhexidine scrub and solution to prep it. Okay, I have really great exposure of this vein. So let's scoot her towards the camera. Okay. Man, it's so hard to position this. Yeah, put her leg out like you. Yeah, right like that. Okay. Excellent. Alright, and then hold off. Yep, perfect. Alright, you're not going to like this. She's going to wiggle. It's going to hurt. Oh, good girl. You're so good. Aren't you brave? There we go. Got a good flash. There we go. Alright, you can let off that hand there.
Oh, baby.
Excellent. Okay, so I got my catheter in. Man. There we go. And then I'm going to go ahead and anchor it. Tape. And then if you want to just kind of hold her leg so she can't pull it back on me. Thank you, ma'am. Okay, I'll put one underneath to anchor it in. Gosh, let me wrap the leg. All right, and then I'm going to put on a wrap over on top of it with the vet wrap. Right there with some no chew wrap so she doesn't chew it out afterwards. Okay. There we go. Perfect. Okay. Chlorhexidine solution. Draw that hairs out of the way. Alright, if you hold off for me. Okay, it's okay. We'll place our IV catheter. Will you grab them lube? Eye lube? It's up there. Poke here. Good girl. It's okay. Alright, I've got a good flash here, so I'm going to go ahead and thread my catheter. Alright, thank you. And then I'm going to put the tape on. Anchor it in there. Of course, the gloves make it very difficult. Finish putting. I'm going to put a T-port on here so I can run IV fluids during the procedure. And then make sure that's anchored in. The trick is having a really great holder like Emily, of course.
come back around and anchor it in. Alright, that's nice and anchored, and then I can cover it back up with my gauze, my vet wrap. Alright, doesn't look too pretty, but at least we're nice and anchored. And then of course I want to flush it, just double check it out on the end. Perfect. And I'm going to give it to her intramuscularly. So in the back of her hip here. Alright. Right behind this leg. Girl, I'm sorry. Oh, you're so brave. Good girl. Alright.
Tent up the skin a bit and inject right there. Pull back, make sure I don't have any blood. And then inject. Oh no, good job.
Put a little alcohol in the area. It's okay, honey. Oh, don't be silly. Hey, okay. You're all right. Yeah. So I injected the bevel up. Good girl. And draw back till I get a little flash of blood. I don't know if you can see that. There we go. And then I go ahead and inject. Good girl. See, that wasn't so bad. So now we're going to do the propofol and have her induced. And a side effect of propofol is apnea, where they don't breathe, very well. And so that's why we kind of give it slowly and we titrate it with the LRS. So you want to just give it to effect. So when she's relaxed enough to where I can place a tube. And the way you can tell she's relaxed is that her third eyelids kind of start coming up, and they are a little bit. And she's got a little bit of a palpebral reflex there. And she opens her mouth easily. She's still got some jaw tone there, so she's not quite ready. She'll probably really fight the tube if I try to tube her now. But I bet once I'm done with the propofol, she'll be good to tube. Hey. And when she's relaxed like this, we'll go ahead and give her eye lube. When they're asleep, they don't produce tears. Their ducts kind of slow down. So you want to kind of make sure you leave their eyes so they don't get dried out. And of course, they don't blink, when they're relaxed like that. Okay. See? And the tongue goes in the middle and pulls down her jaw. Perfect. So now I can easily see. Oh yeah. All right. And now you close her mouth and kind of hold it right there. And then I'm going to attach your tube, and we'll start at 3 and 3. And then you stay right there while I tie her in. And then I'll blow the cuff up. Okay. All right, perfect. Open her mouth just a little bit for me. Perfect. All right, excellent. Thank you, ma'am. And you can let go now that it's anchored. Okay. Interesting tube. Yeah, it's from an IV line. Make the best tubes. All right, so now she's successful. So I close my puff-up valve all the way. Okay. And I place the syringe here. And then I squeeze. Till I can't hear any air coming around. I still can hear air, so a little bit more. Now I can't hear any air. And then, of course, I always want to release that pop-off valve. Okay. I can palpate on each side of the trachea to make sure I only have one tube and that it's in the trachea and not in the esophagus. I don't feel it. I can also open up her mouth really well and look and make sure it's in between the laryngeal flaps.
We're expulsing his bladder to get that urine out. Very bloody.
So I'm going to do a clip, and I'm going to start right up here above her ribs and all the way down, kind of like all her abdomen, starting at the end of the ribs. And first I go away from the hair, or with the hair, excuse me, and then I'll clip against the hair to get a good initial clip. Okay, next I'm going to go ahead and do my rough prep. And I always want to start from the incision line and work my way outside in a circular motion, never coming back into the middle. And I want to prep her for about 5 minutes to get a good clean scrub. And contact time should be about approximately 5 minutes, so about 3 scrubs should be good. And I start with a Chlorhex scrub, and I rinse it with Chlorhex solution, and then at the end use an alcohol to rinse her off completely so that our skin isn't reacting to the chlorhexidine. Okay, now I want to do my alcohol rinse, so I'll soak my gauze alcohol. Oh, we put on a hair one too, thank you, sorry. And I'll do my alcohol rinse as well. We're going to use the sling where we grab each side, one over there and this over here, and then you be really careful about not getting the surgery area. Watch your head. Okay, and then grab it real good like this. Yep, and we'll pick her up like that. Okay. Alrighty. Okay, perfect. Okay, so now I got her secured to the table with these leashes, and if she wakes up, she won't be able to move off the table. I'm giving her a positive pressure breath, just so we can avoid atelectasis, where the lungs won't inflate to their fullest while under anesthesia. I also, every 5 minutes, want to do a hand, listen to the heart rate by hand, because you can never trust machines. Although the sounds make it a lot easier. I mark it down every 5 minutes. I want to monitor her blood pressure, which is on her front left leg. Her heart rate, of course, which I just heard. Which was 120. Her temperature is measured by my esophageal stethoscope, and it's at 98.6. Her respiratory rate, which I can measure by watching, or I can also see my bag and it moves. So we're at 20 respiratory rate. And I check our mucous membranes, make sure they're nice and pink and healthy, and that they have a nice quick refill time. My blood pressure reading, my machine here is 102/54 with a map of 70, and I can see my probe reading at 98, and my temperature has now risen to 100.5. And then I just took my heart rate, and I make sure I do that every 5 minutes. Okay, so I'm going to demonstrate what happens when my animal needs to be resuscitated under anesthesia. If he were to crash, I couldn't find a stuffed animal, so I'm using a towel pet. This is a dog. This is its head, its body, and its tail. You always want to have emergency drugs, of course, nearby in case the doctor needs them. You need to be able to have easy access to them. So basically, you want to do your chest compressions right over the largest part of the dog's chest. If it's a large dog, medium to large dog. If it's a small dog, you use your hand right over the chest area, and you do about 100 to 120 beats per minute. 1, 2, 3, 4. Stand up. 1, 2, 3, 4. And I just continue. I don't want to stop with the compressions. Unless I get tired, someone needs to immediately switch out with me. The person would close the pop-off valve and give a full breath to the patient. Open the pop-off valve so that they can breathe out. And it's easy because you don't have to use a pop-off valve if you use an ambu bag, and you give them one breath every 6 seconds. So 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. You don't want to do fast breathing. You want to do it like they would normally breathe. So if it were a cat under anesthesia that also went into cardiopulmonary arrest, your breaths are going to be a little bit quicker, and then you're going to choose and just use one hand right directly over the chest and do compressions at the same rate, 100 to 120 beats per minute. Alright, I gotta use my Baby soap. I'm gonna start out with doing my nails first. Those are really good. And then I want to start working down my fingers. Make sure I get all around my fingers. Hand real good. Other side of my hand. And then work my way down my wrist. With my elbow. I want to do the other hand. Start with my nails here. Alright, now that I'm done washing, I'm going to rinse off my hands. I'm going to start with the fingertips. And then I go towards my elbow. That water's hot. Get on this side. Elbow. Okay. Alright, my video timed out, so I had to have someone come turn it back on for me. Alright, so I get my towel and I start with my tip of my fingers. And I draw my fingers. And then I work down my hands. Sure not to get anywhere I haven't done. Okay. And then other hand, fingers. Start with those first. And down my arm. Make sure I'm nice and dry. Alright, I'm ready to put on the gown. Alright, so first I want to grab it by the corners. Like that. Fun little things here. And do it here. Put my arms through. Sure. Up and over, not let my hands come through. Okay. Alright, and then I want to start on the gloving. Okay. Let's see. Okay. So I want to pick up my left glove with my right hand. Okay. And place it on top of this hand and grasp it the corners here, and then start pulling it over and wiggling my hand inside of it, making sure my hand does not come out around the sides and make it unsterile. There you go. Alright. And then next I want to wiggle my hand out. Ooh, just need it. Okay. Alright. Let's go. Okay. I think this
this is probably one of the hardest things to learn is the gloves. Okay. I didn't break any sterility. I'm trying to wiggle my hand out and into the glove. Okay, there we go. Whew. All right. And then I use this hand to grasp inside the right, not to touch the table. And it'll open up over my hand. This is closed gloving. Top here. So I don't break any sterility again. Okay. And wiggle my right hand into it. Okay. All right. Okay. Okay. So now I keep my hands up, my gown on, above. Keep them up here. I've got my blade, suture, and then I'm going to open up the second pack. And I want to prepare my scalpel with the blade and get everything organized and ready. My instruments. Okay. Alright, and I've got her needle holders here, and blade handle here, and forceps. And I'm going to take my blade and my needle holder. I'm going to go ahead and place it.
I don't see drapes marked.
No? Alright. On there. Okay, so now I got my scalpel blade on there and my needle holders. And so I set those aside for her to use. And then with her scissors out as well. Hemostats ready to go. And then I'll get my clamps, towel clamps too ready so I can drape in. Drape my patient. Okay. Alright.
Do I have it down?
Oh, yes, at the very top. Yeah. And then I'll use the correct scissors when I cut this, which are the Mayo scissors. Cut an area in the middle where the incision will go. Place it right over top of her. And then don't touch this blue drape. Okay. And then I'll cut the hole where her incision will go. Okay. Place that right in the middle there. Okay. And then I'll place my towel clamps on top.
Alright, tell me when you're ready, because I need to be on that side.
Okay, I'm just clamping the towel clamps in, and I'll be ready.
Hey Sam, turn my little switch on up there. See my light on the top? No, here on my head. That little thing.
Okay.
Thank you.
One over here. Let's see, is this the correct spot here?
I need these lights turned on too.
Okay, that.
That's why I was like, what the heck? And now they're connected, so it does kind of.
Alright, there, that's better.
Okay.
Alright, do you need another clamp at all?
I think
Okay.
that's good.
Excellent. Alright, we've got our cat spay, and I'm just going to blot the tissues when they bleed. And you want to be careful not to actually scrub or wipe, just touch and collect the blood so you don't pull away any clots.
You want to blot that for me and see.
What happened?
Flush that.
Yeah, so now I'll
flush the insides and then use some gauze, wet gauze, in order to kind of keep it nice and moist.
Scissors.
Scissors, okay. The Mayos, no, the medicine bombs, correct? That you're right here.
Those are next month. I need the other one.
Okay.
Thank you. Just gonna make my hole a little bigger.
This is the first time I've done.
All right, and I need a tin blade and a scalpel and a gauze. Thank you.
The gauze ready.
And I will need, thank you. Give me the medicine bombs.
Okay.
Oh,
sorry.
That's okay, and I need thumb forceps, the brown essence.
Okay. Right here.
Okay.
Thank you. And then of course it's important that we do not break sterility. If one of us were, or if Dr. Sears were to drop an instrument, we would have to clean it really well and flash sterilize it if she needed it again. If she didn't need it, and sometimes we do have replacements that are already individually autoclaved, but if she didn't need it, then we would not be able to put it back in the pack. We would just go ahead and put it to be cleaned and added later in the pack when she was complete. This is our little dog neuter. And then we still want to monitor her heart rate. Okay.
So our surgery suite needs to get cleaned, so we take all of our blankets into our area to be laundered. Any sharps that you see do need to go into the sharps container, of course. We've already taken care of our surgery pack, so we definitely want to wipe down our Mayo stand. We want to make sure we do inside the light as well, both lights and then up the arms too. Make sure we do a good job wiping those. We also want to make sure we wipe off our anesthesia machine, make sure all of the tubes get washed and soaked. All of the parts definitely that can collect dust. There's the lead on top, and on top of our monitors, of course, we want to make sure that's clean. We want to make sure all surfaces are free of dust. So all of the parts get wiped off and they get cleaned, and this gets specialty cleaned with some ISO or some chlorhexidine cleaner to make sure it's not contaminated. And then they get wrapped up and put away. And then of course, once it's time to mop, we use a specialty floor cleaner, and we use a surgical mop only. And we use our mop to spray the floors down really well after we vacuum. And then we take out the garbage when we're all done. This instrument enzymatic cleaner to clean our instruments with. That's one there. So I want to do a pre-soak for a few minutes. With each of the instruments. After the pre-soak is finished, I want to make sure I decontaminate my instruments. So I use the water, a soft bristle brush, and make sure I get all of the parts inside to decontaminate the whole thing. This is our ultrasonic cleaner. It's got the Ultra Clean solution in it, mixed with the Ultrasonic cleaner, mixed with distilled water. And I put my instruments inside, and I set the timer so that they can be cleaned well, and I set it for 15 minutes. Okay, now that my instruments are all dry and laid out and ready to go into its pack, first I place 5 and 5 sets of x-ray gauze inside my pack. And then I'll place my scalpel blade, and then each of my thumb forceps, 3 different kinds here that she uses. And then I want to organize my scissors and my needle holder together. And then after that, I go for my Carmonts next, 2 of those in each pack. My Alice tissue forceps, and then my Kelly hemostats and my mosquito hemostats. And I like to make sure they're nice and organized, and the doctor likes to have this put through in the middle to kind of keep them together and they don't bounce around. And then on top I place my my towel clamps, and then I place an indicator strip on top, of course. Make sure that it comes out nice and sterilized. Next, I want to wrap my pack, and I do it with the 4 corners. So first, I put my first corner up crosswise and tuck it down so it's got kind of a lip here, and I want to make sure it's tight and there are no holes. And then I place the next over on top, and then I fold the next one on top. And our doctor likes to do two cloth drapes. Okay, and then on top, and then I tuck it inside. And then for the final one, I'll bring this corner up just like I did on the underside. Flap out to easily pull it open. And then we tape it across really well with a piece of masking tape, and then also we use indicator tape to make sure it is closed well. And then we write the date and our initials on it. So I'll have my initials as OB, and the date today is 11/4/19, and this is a yellow spay pack. And then we take it to the autoclave and autoclave it. Clean and laundered. So what I want to do is fold it with the sleeves, grab it kind of on the corners here with the sleeves inside as I turn it inside out. So the sleeves and the outside of the gown are the sterile part, so it's going to be on the inside, and the inside of the gown facing the surgeon is the non-sterile part, so it's going to be on the outside to keep it as sterile as possible. And then we kind of accordion style, and then place it in the middle of our wraps, and accordion style it down so it's easy for the surgeon to pull it up. Okay, and then we get our strings, make it easy for them to grasp. So the blue towel, you also accordion style fold it. Okay, and then you get an indicator strip, place that in there. And then you start wrapping it just like you would a pack with the corners up, nice and tight. And the next corner up and over with a little flap down. You don't want any holes. Okay, and then these corners get folded in, and this top comes around and tucks in. And then the second layer, the same thing. Pull it around tight. Gown and towel with the date that it was autoclaved. Okay. With my initials. So that's indicated there, and then you want to put on a piece of indicator tape as well. Alrighty, so now it's ready to go to the autoclave. Alrighty, so this is our ultraclave sterilizer, autoclave sterilizer, and it's nice and automatic, and it uses steam and pressure to sterilize. So we open up the door and we want to place our pack in and make sure there's plenty of space around it. Okay, so I stick it in there and I make sure there's plenty of distilled water in the green area. And then I go ahead and close and clamp it. And then I choose my pack. So I'm going to sterilize it for 30 minutes and 250 degrees Fahrenheit. And so I choose my pack, and then I push start, and it starts it up. And it has many different choices. I can do pouches, unwrapped, and hand pieces to make it a little bit quicker if I need to hurry and get something flash sterilized. So this autoclave does require routine maintenance. Weekly, it needs to be weekly cleaned. All of these parts get removed and cleaned really well with a damp cloth and the appropriate speed cleaner. We have autoclave cleaner here that we use. We dilute with sterile water and we wipe everything out real good. And then these are the drain filters that we need to scrub once a week and make sure they don't become clogged, because if they become clogged, then we have a problem and it won't autoclave properly. And once a month, we empty out all the water, and we use this tube, empty all the water out, run a cycle of the cleaner, and drain all of that out. And then we run a cycle with just sterile water, drain out all the sterile water, and then we refill it again, and then we can use it again. But that does a really good cleaning of the whole thing. Okay, so I know that my packs have gone through the autoclave because the indicator tape has changed color on my pack and my gown. And the only surefire way to know, of course, is when we open them up in surgery and we show that indicator has changed colored as well that's inside the pack.
It's actually way too early to take these stitches out. There's a lot of puckering. The incision is still a little bit open. It's only been about 7 days on her, and she's got a lot of healing left to go. So we're actually going to leave these stitches in for a few more days, make sure she's completely healed. If we take them out now, I'm afraid that it might just dehiss and open up again. I don't want her to get infected. Okay,